I am the most junior member of Enbridge. I'm very proud of that. I probably stand to benefit the most from these collaborations. I'm probably closer in experience to some of the residents here than to the members of Enbridge. And part of what I'm going to talk about today is my initial experience with trying to develop a program that I felt I was ready to implement. I looked for mentors in the field that could guide me towards creating a program that provided a valuable service to patients. And what I encountered is that there was so much that I didn't understand and I didn't know, and there's just so much more that I need to improve so that that delivery of care is appropriate. And I think that that's where I will make my impact, even though that initial year was met with frustration, with disappointment, and oftentimes with just feeling a little bit helpless at the barriers that we have to overcome so that these patients can get appropriate care. The story of spina bifida and adult spina bifida is a success story for pediatric urology. These were children that would often not make it into adulthood, and now we can say that there are more adults living with spina bifida than there are kids with spina bifida. Right now there are about 150,000 adults with spina bifida living in the United States, and that's an amazing achievement for pediatric urology. We know that it is a population with a lot of medical complications. We also know that they need to be surveyed for their lifetime, and they will have recurrent problems that need to be addressed throughout that lifetime. And we know that we can detect complications by following the patients, but we don't yet know what the best way to do that is. One of my colleagues, Dr. Azwar, is going to talk about the different frameworks in which to develop a transition care program, and I'll talk to you about the model that we utilized and some disparities that we identified in implementing that model in a place where there are a lot of underserved patients and a lot of minority patients. I was hired to be the adult urologist at UC San Diego Health, and one of the cornerstones of my hire was that I was going to create this program in collaboration with the pediatric urologists at Rady Children's. And what we developed through mentorship with other adult urologists across the country that had developed similar programs was a clinic that was centered around a collaborative model. We knew that the adult urologist was going to be the center of that model, but that there would need to be some kind of support for that urologist to be able to attend to the needs of this high needs population. So we implemented it with a physician assistant. We also knew that the role of nursing was going to be really important, so we identified a nurse epidemiologist that was going to allow us to prospectively look at our ability to implement the clinic and be successful with it. And we knew PM&R was probably the specialty that had straddled that med-peds transition the best, and that they had really taken the reins for a lot of the transition care, even the bowel and bladder needs, they were addressing very reliably in many institutions. And so we identified somebody there that could also assist us in developing that framework. And so, I was very confident, a lot of energy, a lot of enthusiasm about starting the clinic. And I thought, there's no way this can't succeed. There's an adult urologist, I'm well trained, I have a lot of mentorship. I'm willing to see them, it's going to happen. So to date, it's been a really rough start. It has been a huge struggle. Intrapersonally, between the patient and the provider, there are a lot of difficulties. Patients that need to be asked specific questions. A lot of times they are used to the pediatric urology world and how things are asked there. And if you have a different personality, or if they're seen by one of my partners who has a different personality than I do, they may not jibe well with that person, and they may not return. A lot of their response to not feeling like they're getting adequate care or their needs met is to not return. Between providers and the patients and the nurses and the patients, there's a lot of misunderstanding in terms of what needs they need to address with the patients, and it's also hard to make sure that there's good communication between all of the clinics and hospitals involved. So there are multiple barriers. Throughout the program's establishment, we followed patients with several questionnaires. One of them may be familiar to a lot of you in this room, which is a transition readiness assessment questionnaire. And it evaluates patients in a series of multiple domains: their ability to manage their meds, their appointments, their ability to advocate for themselves, and their ability to manage their life, pay their bills, attend their appointments, have a job. And what we noticed is that the patients that were transitioning, compared to our neurourology patients, our adult neurourology patients, the stroke patients, the Parkinson's disease patients, they scored significantly lower in self-management skills, and that 4.5 to 4 score is actually quite a difference in scoring. But they were comparable in terms of their self-advocacy skills. So even if they weren't coming back, they were letting us know that we were not meeting their needs and that they did not feel prepared or satisfied with the transition. So what are the early statistics? How did we fare with the referrals and their coming to clinic? We had 54 total referrals from Rady for patients that needed to transition from that pediatric population to the adult side, and 30 patients transitioned successfully. That means that they came to see me at least once. That's the definition of success. By no means is that success if they came to see me once and then didn't come back for any of their studies, but that was a definition. So you can see with that paltry definition of success, we still have almost half of the patients not transitioning to seeing an adult provider. So it's not a lack of availability of the clinic. It doesn't have to do with my personality. They're not even coming to meet me, and so that creates a lot of questions. First off, it's a predominantly Latino community. 70% of the patients are underserved, and I hypothesized that there was a big issue there that we were not identifying in terms of the transition taking place. What we were attempting to do was create a shared care model in which they would be shared between Rady and the adult hospital, and we would see them frequently and give them the questionnaire and really monitor them, but they were not even coming into that appointment. And so we aimed to look at the preparation towards transition and try to see if we could identify things that were happening even before the transition took place that might predict or might highlight why we weren't succeeding at transitioning the patients. Because it's an underserved community and there are a lot of minority patients within that community, we postulated that there might be some disparities related to race or ethnicity. Obviously, we know that for many health conditions, there are racial and ethnic health disparities. In congenital urology, we haven't really examined that. There are some small papers actually published out of UCSD. One of my partners, George Chang, has really looked at that idea, and it shows that these patients tend to be more obese, they tend to have less ability to mobilize, they have less assistance, and a lot of it has to do with their economic disparity, it has to do with their literacy, and it also has to do with their race and ethnicity. But what we also know from the congenital literature is that we don't prepare patients appropriately to transition, whether they're white, black, Latino, they're not getting prepared appropriately. And young adults with congenital urologic conditions do have poor access to care, and the situation is likely worse for minorities. So how did we do in that respect? To understand the results that we got, we first looked at the framework that we were building our practice on and the types of barriers that could exist so that we could examine whether any of these variables were different and were affecting the outcome, which is that we wanted them to have continuous access to high quality medical care. And so in preparing patients to have that high quality medical care, we need to prepare them to change their care from a pediatric to an adult provider. We need to prepare them for insurance changes, which we'll go over in a little bit. We need to assess how they can care for themselves, because at no institution is the level of intense care that they get in pediatrics going to be equivalent to the adult model, nor do we want it to. We need them to be adults. And so that we need to assess how ready they are to do that. And then in terms of education, job planning, independence, and what we call self-advocacy, how well are those patients going to fare, and how well did we prepare them before they even transition? So what we did was a transition care assessment of patients between the ages of 13 and 17, which was the age that we identified based on previous literature that's the appropriate ripe age to get patients ready to transition. And so we had a representative sample of patients across Rady in different conditions, cystic fibrosis, congenital aortic valve stenosis, tetralogy of Fallot, cerebral palsy, spina bifida. 13% of those 3,000 patients were urologic patients. And then we did a survey assessment of 4 domains that we just talked about: the changing healthcare needs, the care transition from adult to versus pediatric provider, the eligibility for health insurance, and self-responsibility. And had the patients assess themselves as to how prepared they felt, or how often their providers, any provider, physician, nurse, social worker, had talked to them about these specific variables relating to their transition and had helped them prepare for that imminent occurrence. And what we found was, first of all, a good outcome meant that all 4 were addressed. And what we found was, even in patients that weren't minorities, the majority of them were not getting adequate preparation for that transition. So 47% of non-Hispanic white youth actually got those 4 preparedness screenings. And this is the patient's perspective. And really, it doesn't matter if you did speak to them about it. If they didn't feel like you prepared them for it, then you didn't succeed. When you look at Black youth or Hispanic youth, the numbers are much lower. And it's concerning because almost a quarter of them are receiving the adequate preparedness that they need, which means that 75% approximately are not being prepared to transition. And then when you look at it that way, then you're not surprised that your program isn't succeeding. It's not even getting out the door appropriately. And when you look at it on multivariate analysis, minorities had 1.5 times the odds of not reaching the appropriate transition readiness outcome. So we don't prepare them well at all, at least at UCSD, and we're really trying. Again, this is our conceptual framework this is where we'd like to be, clearly not there. And we need to be. At UCSD, the transition population, 65% Hispanic, 72% if you just look at the ones with congenital urologic conditions. And if you go to my transition clinic, it's mostly in Spanish. And another barrier is that a lot of them are not US citizens, which presents the next barrier, which is insurance. Young adults, any young adult, healthy, not healthy, congenital, not congenital, will have lower rates of insurance coverage. They're young. There's a gap that occurs when they're no longer at the age of 21. They don't get comprehensive coverage. And then the complete coverage that they can have through Medicaid expansion and through the Affordable Care Act changes that allowed them to be on their parents' insurance until the age of 26. That's a complete-ish coverage. It doesn't include the comprehensive care that we would like congenital patients to have. the insurance that they require needs to be really robust because they need a lot of care. Part of the reason for this is the employer-sponsored insurance model. A lot of younger patients, the congenital patients, some of them are not able to work in a job that provides them with health insurance. But even the ones that are typically employed in lower wage positions where that's not a possibility. So the transition population does have some access to better insurance coverage if they can qualify for Medicaid, or in the ones that are at risk for kidney disease, and I try to apply for all of them because they are, especially if they have spina bifida, they are at risk for long-term kidney failure, but not all of them are going to get Medicare. And if they're not citizens, then it's really difficult. That said, we still, at UCSD, if we had prepared appropriately, would have been able to capture those patients because we have charity care. And those patients would have been able to apply. It takes time, it can take up to 6 months, but they would have had the coverage. So preparing ourselves would have made it a little bit easier. So in that transition population survey, when we looked back at the patients that failed to transition or never showed up, 27% had had a gap in insurance coverage, and 13% of those, once they identified the gap in coverage, never returned to the system, and we were never able to get them back. There's a lot of hypotheses as to why that is. Sometimes thank you so much. Sometimes the political climate can have an effect if they feel that their status as citizens is somewhat threatened. If they self-identify and try to apply for charity, they might feel like they're at risk for being deported or suffering some other consequence. That's an unproven hypothesis, but the fact that outreach to get them back into the system has been so difficult, I suspect has something to do with their fear of identifying themselves, when in the pediatric population, that was never a question that was asked. So non-citizens are at highest risk of loss because they're not eligible for the comprehensive Medi-Cal that would have been able to capture them and bring them back into the system. So as we discussed, that gap really impacts our ability to transition patients effectively. It's certainly one of the 4 domains that we need to address. There are 3 others that we won't go over today just for scope of the talk. But one of the things that we've tried to frame shift in our development of this program is to really put more intense time into the preparedness phase. And then, we are still ready to catch them when they transition to the adult clinic, but we need to put in more time and energy into the preparation stage. So now what we've done is the adult urology team has become a part of the Rady team, and we see patients physically there at that hospital. It creates a level of trust with the patients, and we're trying to see if that will implement some of the preparedness stage in terms of them being able to feel comfortable transitioning from their pediatric hospital to the adult hospital because they already know their adult providers. And that will begin between the ages of 13 and 16, depending on their preparedness. Once that preparedness phase is tackled, we still have the adult side of the equation that we want to address, and then the challenges are different. So now that the preparedness stage has been addressed, then as adults we need to empower them with UTI prevention, and we're using care coordinator models to implement all of these things. We want to address their continence, which becomes a huge issue as they become adults. We continue to want to look at their ability to advocate for themselves and be responsible for themselves. And obviously, we want ultimately to have them feel like we have improved their quality of life, because that's what's really going to bring them back to the clinic. We've used a few pilot programs. Thankfully, we have gotten a lot of funding from, from our institution. We've identified superstar patients that have transitioned successfully, and we've made them patient advocates. We have them come to clinic, and they talk to the patients. They administer questionnaires. They are preparing videos. They'll call patients. They'll go to the school to talk to the teachers about the needs of spina bifida patients, and that's been super helpful. As part of that, we do school and community education. I've gone to schools to explain to Mrs. Perez why she needs to let the child go to catheterize themselves every 2 hours when they just got an augment, so that they don't have accidents in school. Explaining, how the augment is to stretch over time. It's, there are a lot of barriers in education, and then we've engaged some local community groups as well to help us disseminate the word to the community about our embrace of this population and how we want to improve the program for the patients. Hopefully, this will be something that can be more successful as time goes on. I'm fortunate that I get to struggle through all of this in San Diego. If I ever get stressed out, all I have to do is go to the beach. But it's a challenging process, and the more you delve into it, the more challenges arise. Thank you.